Thank you very much, and good day. It's a pleasure to be here with you today to talk about best practices in disinfection of non-critical surfaces in a healthcare setting using a bundle approach. So today we're going to go through a series of slides that discuss essentially how we use a bundle involving policies, products, education, compliance, and no-touch room decontamination technologies. Let me begin by mentioning this presentation is sponsored in part by Alchemedica. Let me mention that the slides for the presentation are available at the website disinfectionandsterilization.org. Now, you know that the environment contributes to healthcare-associated infections. We know via various evidence that the environment contributes to include epidemiologically important pathogens like MRSA, VRE, and C. difficile. We know the surfaces are contaminated at a frequency of approximately 25%, that these organisms survive for days, weeks, and months, and that contact with these surfaces results in hand contamination. And when we disinfect the surface, that reduces that hand contamination. So when we disinfect surfaces, we reduce hand contamination, which reduces healthcare-associated infections. One unfortunate factor, however, is that rooms are not adequately cleaned and disinfected, and we'll discuss how we're going to resolve that particular problem. As far as this practice goes of disinfection, we know that if we don't properly disinfect a patient's room, we'll put the next patient at risk for the previous patient's pathogens. For example, if you or I went into a room and the previous patient had C. difficile, we have about 11% risk of acquiring C. difficile. If we went into a room the previous patient did not have C. difficile, we have about a 4.6% risk of C. difficile. So our risk of C. difficile is increased by 235% by the mere fact that we went into a room with the previous patient having C. difficile. The reason for that is surfaces are not adequately cleaned at terminal or discharge cleaning, leaving these pathogens, such as C. difficile and other epidemiologically important pathogens, present on surfaces, and the patients being exposed to those pathogens, either directly or through the assistance of hands of healthcare workers. As far as how these organisms essentially transfer, we know that healthcare workers touch environmental surfaces. And we also know that those surfaces are contaminated at a frequency of approximately 25%. So healthcare workers essentially touch these surfaces and contaminate their hands. Now, if there is not proper hand hygiene or appropriate glove use, they can transfer that pathogen to the next patient. We also know that the hands of the patient can touch contaminated surfaces, and they can bring those contaminated hands with epidemiologically important pathogens to their eyes, nose, and mouth, which could result in infection. So we're going to discuss how to reduce the environment contamination and how to do that using a bundle approach. Now, a bundle approach is a set of evidence-based practices. So these 5 practices that we're going to discuss essentially have been proven in the peer-reviewed literature. And we know when these 5 practices are performed collectively and reliably, they've been proven to improve patient outcomes and reduce healthcare-associated infections. The 5 practices that we're going to discuss include policies and procedures, products, education, compliance, and no-touch room decontamination technology. Now, we have mentioned epidemiologically important pathogens, and we've alluded to the fact that those pathogens include things like methicillin-resistant Staph aureus or vancomycin-resistant enterococcus or Clostridium difficile. But there are other pathogens that can be transferred via the environment via hands to essentially the patient in a healthcare setting. When we mentioned that approximately 25% of surfaces are contaminated with these epidemiologically important pathogens, that comes from various data in the peer-reviewed literature. This is only one summary involving the level of contamination with MRSA. And if you look at this particular slide, you will see that overall, the level of contamination in rooms of patients that are colonized or infected with MRSA is approximately 37%. And it varies by, of course, the object that is assessed or evaluated. Overbed tables have a frequency of contamination of 40%, or better side rails have a contamination rate of 27%. So overall, approximately 25% of surfaces in a patient room would be expected to be contaminated. Now, the problem is that these organisms don't die quickly. These epidemiologically important pathogens survive for days, weeks, and sometimes months. You can see the survival rate for Staph aureus, for Enterococcus, Acinetobacter, and Clostridium difficile. And you can see that it varies from days, weeks, and months. So these organisms remain on these surfaces for a period of time unless they are removed or inactivated by a disinfection procedure, and that's what we're going to discuss. Now, one thing that's important, and it's actually a change in the last 10 or so years, and that is that healthcare workers acquire pathogens as frequently from touching environmental surfaces as they acquire pathogens on their hands from touching the skin of patients. This particular slide shows that there's no significant difference on contamination rates of gloved hands after contact with skin or environmental surfaces. So our healthcare workers are acquiring pathogens on their hands as frequently by touching environmental surfaces as by touching the skin of hospitalized patients. Very important point. We also know relatively recently that we can interrupt transmission of infection via the environment by cleaning and disinfection. There was a very nice summary a few years ago by Dr. Donsky, and that summary essentially concluded that improvements in environmental disinfection may prevent transmission of pathogens and reduce healthcare-associated infections. And that's really what we're going to talk about today. Now, as we mentioned, environmental contamination leads to healthcare-associated infections. Now, we want to interrupt that transmission cycle, and the way we're going to interrupt that transmission cycle is by cleaning and disinfection. Now, when we do disinfection regimens, we don't intend to produce a sterile environment. We're not going to render all environmental surfaces devoid of microbial contamination. What we are going to do is we're going to reduce the risk of acquiring a pathogen from the healthcare environment and from non-critical patient care items by reducing the level of contamination. Now let's begin with our bundle. Remember, a bundle is 3 to 5 things, which when done reliably and collectively, reduce the risk of infection. Now, as I said, we're going to review 5 items, the first of which is develop policies and procedures. At UNC hospitals, we obviously have policies and procedures as it pertains to disinfecting the healthcare environment. So we work in collaboration with our environmental services to identify how we're going to clean and disinfect inanimate objects. We're talking about environmental surfaces, and we're talking about non-critical patient care items. So let's see what we're going to do. Well, as I alluded to, we have to have policies for environmental services to operate from. So the policy that UNC hospitals generated was done in collaboration with environmental services and infection control, and of course defined how surfaces were going to be cleaned in our hospital setting. So we had to standardize the cleaning and disinfection of patient rooms and pieces of equipment throughout our hospital. We wanted to make sure that all touchable hand contact surfaces were wiped with a disinfectant daily when spills occurred and when the surfaces are visibly soiled. We also wanted to make sure that non-critical medical devices would be disinfected daily and when soiled. So there are certain practices that we had to ensure were in our policy, and we had to ensure that there was compliance with our procedures and our policies during the course of implementation of our cleaning and disinfection activities on a daily basis. Now we're going to review essentially some of these best practices for cleaning and disinfection. Now I should mention that cleaning and disinfection is a one-step procedure with a disinfectant detergent. So essentially we have a disinfectant detergent. It's one step. That is, the detergent essentially removes organic materials, and a disinfectant inactivates the organisms on surfaces. So it's a one-step procedure. No pre-cleaning is necessary unless spills or gross contamination is present. So in generally, it's one step, but in cases where there's a significant spill or gross contamination, we would have to clean that surface or that non-critical patient care item before we use the one-step disinfectant detergent. Now, as I alluded to, we have non-critical patient care items. Now, you probably know the definition of non-critical. It's essentially an item that has contact with intact skin. So an item that has contact with intact skin would be considered a non-critical patient care item, of course, if it was involved in patient care. And we have a policy at UNC hospitals that we would use a disinfectant detergent, and we would have at least a contact time of 1 minute, and we would ensure the frequency of disinfecting these non-critical patient care surfaces would be done minimally when visibly soiled and on a regular basis. And at UNC hospitals, that regular basis was at least daily. So you have to define in your policy what the frequency of cleaning is. It should be done minimally when visibly soiled and on a regular basis, and many hospitals have chosen a daily frequency as the frequency for disinfecting these non-critical patient care items. And we'll see that there is some data that supports that. Now, as far as environmental surfaces, we have recommendations for how we should disinfect them. And we comply with the CDC guideline. The CDC guideline says that it should be done on a regular basis when spills occur and when these surfaces are visibly soiled. Now, again, at UNC hospitals, our regular basis is daily. Now, you can do it more frequently, or you can do it daily. And some hospitals may even do it less frequently, but we're going to see that there's data in the peer-reviewed literature that we should at least do it daily. So we'll talk about that in just a few minutes. But we're talking about housekeeping surfaces. We're talking about, of course, inanimate objects in a healthcare environment, bedside tables, bed rails, over the bed table. All of these surfaces should be cleaned at least daily. And of course, we'll talk about discharge cleaning as well. Now, as I alluded to a couple times, it appears that not only is it important to use a disinfectant, it's also important how frequently you use the disinfectant. We'll see a number of studies, but these studies show that daily disinfection is better than essentially only cleaning when soiled. So we're recommending at least daily cleaning. Now, this is one of the studies that looks at daily disinfection. And you may be able to see these black bars, and then to the left of the black bar is an open bar. The black bar essentially shows the level of hand contamination with C. difficile or MRSA if you only disinfect when soiled. That is, you only disinfect a surface when it's soiled. So you can see if you only disinfect a surface when it is visibly soiled, there is a lot more hand contamination than if you disinfected a surface on a daily basis. Remember, the black bars are the level of hand contamination with C. difficile if you're only disinfecting a surface when visibly soiled, and those empty bars to the left involve hand contamination when disinfecting a surface on a daily basis. So you can see far less hand contamination when the surface is disinfected on a daily basis. And that's one of the reasons that we recommend at least daily disinfection to reduce the level of surface contamination, which reduces the level of hand contamination. So daily disinfection is recommended. There's another paper that demonstrates the benefit of daily disinfection. This particular paper essentially shows that daily use of a disinfectant applied to an environmental surface with a compliance rate of 80% was superior to a cleaner because it resulted in significantly reduced rates of healthcare-associated infections caused by some of the epidemiologically important pathogens like C. difficile, MRSA, and VRE. Now, the other point that I wanted to make is that some hospitals emphasize what are referred as high-touch surfaces. And we don't like, or I don't like to use the term high-touch surfaces because there are no data which demonstrate the value of only disinfecting high-touch surfaces. In fact, if you look at the microbial contamination level of high, medium, and low-touch surfaces, you will find that there is no microbiological difference in the contamination rate between high, medium, and low. So they are statistically similar. So for that reason, you'll hear me refer to disinfection of items in patient rooms as all items that are touchable should be disinfected. I am not going to recommend only disinfecting high-touch surfaces because we really don't know well what high-touch surfaces are. And also, we don't know that only high-touch surfaces are involved in disease transmission. Any touchable surface that is microbially contaminated could be involved in disease transmission. And since there is no difference between high, medium, and low as it pertains to microbial contamination, we feel that we should emphasize the importance of surface disinfection of all touchable or hand contact surfaces. So you'll hear me talk about touchable or hand contact surfaces. That's what should be wiped with a disinfectant. And we've already established the rationale for that. And we said that no pre-cleaning is necessary unless we essentially have spills or gross contamination. So that's the first issue, policies and procedures. We have to have good policies and procedures, and our policies and procedures should follow essentially evidence-based guidelines, and that's what we've done. Now, the second point is cleaning and disinfecting products. We're going to talk about how we select essentially good cleaning and disinfecting products. We've also already talked about essentially this practice of one step with a disinfectant detergent. And we're going to talk about the benefits of a disinfectant detergent being a one-step method involving a cleaner and involving a disinfectant. Of course, the detergent or the cleaning component of the disinfectant detergent removes organisms and removes organic material. The disinfectant, of course, inactivates organisms. So when you use a disinfectant detergent, you're removing not only organisms, but also organic material, and you're inactivating microorganisms by the use of that one-step disinfectant detergent. Now, you can see from this slide, if you look at the yellow highlighted area, that if you have, for example, a disposable wipe with a quaternary ammonium compound, you see approximately a 4.5 log reduction. That's a log reduction greater than 99.99%. Very high log reduction. If you use only a detergent, the log reduction is not nearly as good. It's little less than 3 log reduction. The other problem with using only a detergent is that unless you inactivate the organisms on your wipe, all you're doing is moving the organisms around, and you don't want to move organisms around. You want to essentially remove them and inactivate them, and that's what a cleaner disinfectant does. It removes them and inactivates them. And of course, the disinfecting component of that cleaner disinfectant has the capability of inactivating organisms. Now, you know well that for effective surface disinfection, you have to have an effective product and an effective practice. And when you have a good product and a good practice, essentially you have perfection, or you have removal of microbial contamination at a high level. Now, as far as product is concerned, I'm sure there are many products that are available to you that have good antimicrobial activity. There are papers in the literature which talk about the properties of an ideal disinfectant. And some of those properties include things like broad spectrum, which means they kill a wide antimicrobial spectrum of organisms. They're fast acting. They kill in approximately a minute. They remain wet for essentially the contact time with a single application. They're not affected by environmental factors. They're non-toxic. They're surface compatible. They may be persistent, and they will be easy to use. These are some of the properties. Now, you know that not every product is an ideal product. That is, there's no product, in fact, that is an ideal disinfectant. All disinfectants have advantages and disadvantages, but we try to optimize the products we select so they have maximal advantages. And essentially, some of the properties that we look at are the properties that are listed in this particular slide. Now, as we've already alluded to, in studies that have been done, when you evaluate all those studies and look at essentially improvements in the effectiveness of cleaning and disinfection, and look at essentially auditing and feedback and education, and essentially addition of housekeeping personnel or specialized cleaning staff and automated technologies, we know that all of those things reduce the level of contamination on surfaces and reduce HAIs, and that's what we're going to discuss further. Now, as far as HAIs are concerned, or healthcare-associated infections, what organisms cause healthcare-associated infections? When we look for a product, what organisms are we most interested in killing? Well, you probably know that 7 organisms cause almost 2/3 of healthcare-associated infections. The 7 organisms that cause roughly 65% of healthcare-associated infections are E. coli, Staph aureus, Klebsiella, coagulase negative staph, Enterococcus, Pseudomonas, and Candida albicans. So only a handful of organisms cause the vast majority of healthcare-associated infections. Those are the organisms that certainly we want to kill. And we know we can kill those organisms because they're relatively easy to kill. There are bacteria. Bacteria are very susceptible to disinfectants like quats and alcohols and so forth. Now, there are some organisms that are epidemiologically important that are a little harder to kill. These organisms don't cause a vast number of healthcare-associated infections, but certainly can be problematic in a healthcare setting. And certainly they include C. difficile, and certainly they include norovirus. Now, this particular slide just reminds us that microorganisms have various susceptibility to disinfectants. Some microorganisms are very susceptible to disinfectants. Those organisms include the envelope viruses. SARS is an envelope virus, very, very easily killed. HIV, HSV, herpes simplex, flu, easily killed. They're envelope viruses. Bacteria are easily killed. Then we have fungi, and then we have some of the non-lipid viruses. The low-level disinfectants, what we refer to as low-level disinfectants, and that's what we use on non-critical surfaces and non-critical patient care items, those low-level disinfectants kill the vast majority of pathogens causing healthcare-associated infections. As we saw, most healthcare-associated infections are caused by bacteria. And of course, bacteria are very susceptible to an activation by the low-level disinfectants like the quaternary ammonium compounds, quats with alcohol, certainly chlorine, phenolics, some of those products. Now, this is a list of products that are listed in the CDC guideline as effective low-level disinfectants. you probably have a very similar list. You can see that it includes products that are very familiar to you. Products such as quaternary ammonium compounds with alcohol. Those are low-level disinfectants that are very active in killing healthcare-associated pathogens, and they do it generally in less than a minute. So minimally, we have to have a 1-minute contact time or 1-minute wet time to inactivate the organisms on surfaces. Now, some healthcare-associated pathogens like C. difficile spores are harder to kill. And if we want to kill C. difficile spores, we have to use another product, and those products are sporicidal products. In the United States, we have approximately 35 or 40 sporicidal products. They're primarily chlorine-based. So there's some concentration of chlorine that's effective, of course, against the C. difficile spores, which are harder to kill than those bacteria and those envelope viruses we just discussed. So chlorine-based products are very commonly used for C. difficile spores. There are some other products in the marketplace to include hydrogen peroxide and peracetic acid and a new hydrogen peroxide product. So we've talked about policies and procedures. We've talked about products. Now we're talking about education. We have to educate the staff to ensure they implement our policies and our practices to include appropriate use of products and, of course, thoroughness of applying those disinfectants to surfaces. Now, we have already mentioned the issue of policies and procedures. The point here is we need to educate everyone in our healthcare setting that's involved in implementing this policy and procedure so that they implement this policy procedure consistent with our policy and consistent with the guidelines that are evidence-based. And of course, you know that every place in our hospital should be doing the same thing. So we don't want some units in our hospital utilizing environmental services to clean certain pieces of equipment like vital sign machines or IV pumps. And then other parts of our hospital, environmental services do not do that, and possibly it's done by patient equipment, or possibly it's done by nursing. Everywhere should have essentially the same procedure and policy and standardization of cleaning and disinfection throughout the healthcare system. Now, compliance is also very important. Compliance, what are we talking about with compliance? What we're talking about with compliance is we need to make sure that these products are thoroughly applied to surfaces, so we are effectively removing and inactivating organisms that could be on surfaces and when touched could transmit disease. So what we've talked about is we have to have good policy and procedure. We have to have good cleaning and disinfecting practices. We need to educate everyone that's going to apply these products to include environmental services and nursing about these policies and procedures and the correct application of these products. And then we need to monitor and ensure that these products are applied thoroughly throughout the healthcare setting. Now, that is what we call practice. Essentially, thorough application of the product is what we call practice. Now, why are we making a point of this? We're making a point of this is because several years ago, in fact, for the last 10 years, there are data which demonstrate that although we may have excellent products, we have very poor practices. There are data that demonstrates that if you evaluate the thoroughness of cleaning at discharge cleaning or at terminal cleaning of a patient room, only 30% of the surfaces, touchable surfaces in that room may have been disinfected. If only 30% of the touchable surfaces in that room are disinfected, that means that 70% of the surfaces remain contaminated. And that puts the next patient at risk to the previous patient's pathogen. As we discussed, that can significantly increase the risk of the next patient to that room when that room was inhabited by a patient that was colonized or infected with an epidemiologically important pathogen such as C. difficile. So this data shows us that we are not very thorough in the application of our disinfectants to all touchable hand contact surfaces. So we want to improve our practices. So if we have excellent products but poor practices, because the surfaces are not wiped, we still have very significant contamination of surfaces, which results in a risk of transmitting these environmental pathogens to patients. Now, how do we monitor the effectiveness of cleaning and disinfection? There are a couple ways that are being used to monitor the effectiveness of cleaning and disinfection. They include ATP bioluminescence and fluorescent marker. Now, the fluorescent marker is a transparent, easily cleaned, environmentally stable marking solution that fluoresces when exposed to an ultraviolet light. And the way this works is the environmental service manager, before environmental services cleans a room that the patient just left, or essentially a terminal clean, before the environmental service worker goes in that room, the environmental service manager goes in that room and marks 5 to 10 to 15 sites in that room using this fluorescent marker. This is done unbeknown to the environmental service worker. So then the environmental service worker goes in that room, they essentially clean and disinfect that room, and then when they're done, the environmental service manager goes in to see where the fluorescent dots still exist. And wherever there's a fluorescent dot that has not been wiped, that means that surface hasn't been wiped with a disinfectant, and that surface is still contaminated. So if you put 10 dots in that room and all 10 dots were present using a UV light to monitor or to assess fluorescence, that means that it was very poorly cleaned. All other fluorescent dots remained, which means that there was not very thorough cleaning of the room. If you dotted 10 sites and the dots were all gone, that demonstrates the effectiveness of cleaning, because the environmental service worker effectively removed the fluorescent dot, which essentially is an indicator of thoroughness of cleaning that patient room. And this is what one of those dots would look like. Of course, that you use a UV lamp to essentially identify the dot. That dot is not visible in the absence of the UV light, so you would not see the dot, but of course the dot would be placed. Ideally, the dot would be removed by the environmental service worker disinfecting that surface, and then when removed, of course, that would assist you in assessing the thoroughness of cleaning. Now, the point is that when we have a thoroughness cleaning of 30%, meaning 70% of the surfaces are contaminated, that puts the next patient at risk of the previous patient's pathogen, and we want to improve that. And you can see that when we use this fluorescent marking system, and we use an education of the environmental service worker, and we feed back to that environmental service worker the importance of thoroughness and the fact that they were either thorough and congratulate them, or that they were not thorough and take this opportunity to increase education and increase essentially the importance of their thoroughness in disinfecting the healthcare environment. Now, if you use a method like this, I should mention that you should regularly change the dotted items to prevent targeting of the objects. You don't want to always use the same 10 objects, otherwise environmental service colleagues will know those 10 objects and of course will concentrate on those 10 objects. We want to use fluorescence to essentially improve thoroughness of cleaning. And of course, thoroughness of cleaning is essentially disinfecting all the hand contact or touchable surfaces in the patient room. Now, we've talked a little bit about this. Touchable hand contact surfaces, that's what should be wiped with a disinfectant detergent. The last thing that I want to talk about in this bundle is implementing a no-touch room decontamination technology and, of course, some new strategies. As far as what we have said so far, we've talked about products, we've talked about policies, we've talked about education, and we talked about compliance. Even if we do all of those things well, essentially we are still not going to effectively eliminate microbial contamination in that room. Even if we do effective surface disinfection and use thoroughness indicators, studies have shown that's not enough to achieve consistent and high rates of cleaning and disinfection. And that's why we use no-touch room decontamination technology, which supplements but does not replace surface cleaning and disinfecting. Now, there's many no-touch room decontamination technologies, but the ones that have been most thoroughly evaluated microbiologically and by reduction of healthcare-associated infections are UV and vaporized hydrogen peroxide. We're going to say a couple words about UV as a no-touch room decontamination technology. This was a study that was published a couple years ago, and it was based upon a randomized controlled trial that took several years involving 9 hospitals in several states, cost over $2.5 million. And I'm going to review the data for this particular study. Now, you can see the box there. The box essentially says what the level of contamination with epidemiologically important pathogens there was when a quat was used versus a quat with the supplemental UV. So if a hospital was using a quat only and look for epidemiologically important pathogens, it would be essentially using this methodology, a finding of approximately 61 epidemiologically important pathogens in this randomized controlled trial. However, when that quat was supplemented by UV, the number of epidemiologically important pathogens would be reduced by 94% or down from 61 to 3. So essentially, the UV, of course, supplemented the effectiveness of quaternary ammonium compounds. So the level of contamination with epidemiologically important pathogens like MRSA or VRE or drug-resistant Acinetobacter was reduced by 94%. Now, what happens when we reduce the level of microbial contamination? Now, the next two numbers looks at the colonization or infection rate. If in those quat patient rooms, this study involved over 25,000 patients. In the quat patient rooms, the colonization infection rate was 2.3%. However, the quat UV patient rooms, essentially the colonization infection rate was 1.5%. There was a 35% reduction. This essentially demonstrates that if you decrease the microbial contamination in a patient room, you decrease the risk of patient colonization and infection. That's very, very important. Decreasing microbial contamination decreases essentially the patient colonization and infection rate. So essentially what this shows is that this technology, that is no-touch room decontamination technology, should be used for terminal room disinfection. And what we have tried to do at UNC hospitals is to use it for terminal room disinfection after discharge of patients on contact precautions. Now, if you can't do that because you don't have the manpower to essentially do it for all contact precaution patient rooms, which might be 20% of your discharges, you could do it for certain epidemiologically important pathogens such as C. difficile. The last thing I was going to mention is just a few additional cleaning strategies in disinfection and cleaning, and of course, looking at some epidemiologically important pathogens. As you may be aware, there has been a utilization of wipes to disinfect hard surfaces. And there are several advantages of using these wipes. Now, these wipes, of course, contain something like a detergent as well as a disinfectant like a quat with an alcohol or a quat alone. And you can see the advantages include it avoids improper dilution. So these wipes, of course, They have the appropriate concentration. So each time you use a wipe, it's been standardized. It avoids human errors. Essentially, as I already alluded to, it has the correct concentration of disinfectant detergent. It lowers the risk of contamination and effectively reduces the microbial contaminants. The only real significant disadvantage is, of course, you have to dispose of the wipes. So wipes are more commonly used for the reasons mentioned, to certainly include avoiding human errors and avoiding essentially the issue of microbial contamination. Now, as far as kill time, there are papers in the literature that look at kill time. And you may have on your products a certain kill time for the product, and regulators may recommend you achieve that kill time. As far as the peer-reviewed literature is concerned, it would be ideal to have at least a 1-minute contact time or wet time to inactivate the organisms associated with healthcare-associated pathogens. Speaking of healthcare-associated pathogens, of course, we have always new emerging pathogens. Say a few words about a few emerging pathogens, to include carbapenem-resistant Enterobacteriaceae. This is a study that was published in 2018 looking at 1-minute contact time using a number of disinfectants and looking at a 3-log reduction, or a 99.9% reduction. As you can see, a number of products are very effective, to include quats and quats with alcohol, as well as other products such as improved hydrogen peroxide and alcohol. As far as Candida auris, of course, a globally emerging pathogen that's often resistant to antifungal agents. There are a number of studies now that have looked at the inactivation of Candida auris, and you can see one of the studies on this slide. This shows essentially a quat with alcohol is effective against Candida auris. However, a quat only, or a water-based quat, was not effective. You can see, of course, other products effective, to include not only quat with alcohols, but other alcohol-containing products. As I mentioned, the quat only, or the water-based quat, was not effective against the Candida auris, using an effectiveness marker of 1 minute with a 99.9% reduction. You can also see some antiseptics were not effective against the Candida auris with a 1-minute contact time, to include the 4% CHG and a 0.5% triclosan and 1% chlorhexylenol. Lastly, I just want to say a few words about SARS-CoV-2 RNA. As you know, we have had this terrible pandemic for over a year. You probably know that when you test surfaces of patient rooms for SARS-CoV-2 RNA, that is, you use a molecular test for the presence of the RNA, not the viable virus, you find very significant contamination. In fact, studies have shown that nearly everything tested has been found positive for the SARS-CoV-2 RNA. Again, not the viable virus, but a marker of the viable virus as measured by polymerase chain reaction. You can see the various surfaces that have been found positive for the RNA, to include bedside tables and sinks and toilet seats and blood pressure monitors and so forth. I wanted to mention that certainly recently there's been a study which actually has found not only the SARS-CoV-2 RNA, but also viable virus. So this particular study found the viable virus in about 25% of the surfaces that were sampled, and the surfaces that were sampled were within droplet distance of the patient. So we have found viable virus, the SARS-CoV-2, on surfaces in patient rooms. This particular patient that was positive had high flow oxygen therapy via nasal cannula, but non-invasive ventilation. As far as an activation of SARS-CoV-2, we've already alluded to the fact that SARS-CoV-2 is an envelope virus. Envelope viruses are very easily inactivated, and all the products that you are likely using for cleaning and disinfection in your healthcare setting are going to be effective against the SARS-CoV-2 virus. That includes things like quaternary ammonium compounds, quat with alcohol, phenolics, isopropyl alcohol, chlorine-containing products, ethyl alcohol, and other products. There is a list in the United States, it's called List N, with over 500 products that have been found effective against SARS-CoV-2, and there's over 30 chemistries that have been found effective, chemistries like quats with alcohols, and so forth. As I alluded to, this scheme identifies essentially the susceptibility of microorganisms to disinfectants. And as we can see, the envelope viruses are very, very susceptible to an activation by these disinfectants. So SARS-CoV-2 is going to be inactivated by a number of disinfectants that are commonly used in healthcare. So in the last 45 minutes, we've tried to essentially develop best practices for surface disinfection using a bundle technology. A bundle, of course, is a group of 3 to 5 practices that, when done reliably and collectively, will essentially reduce the risk of infection via environmental surfaces. As we alluded to, the 5 components of the bundle are policies and procedures, products, education, compliance, and lastly, using the no-touch room decontamination technology. As I mentioned, these slides will be available to you at the website disinfectionandsterilization.org. And thank you very much for your participation today.